This is a demonstration of the head-to-toe physical exam as you'll need to do for residency. My name is Michelle Hereford. I'm the director of the NP program. This is Ashley Cheesebro. She is a secretary in the MSN office and acting as the patient for the physical exam demonstration. So you would walk into the room and introduce yourself and say, my name is Michelle. I'm a nurse practitioner going to be doing your physical exam today. And you would wash your hands in front of them. For the demonstration, you can use the hand sanitizer. You would assess their chief complaint. For this exam, have them say they're here for a well exam. So Ashley, what brings you in today?
I'm here for a well exam.
And so as you would look at them, you would assess their orientation. Are they dressed appropriately for the situation, their grooming, their cognition. And you can also state that the medical assistant has done their vital signs, their vision test, and hearing test. Okay, I'm going to start with the head and the face. So looking at her face, I'm looking for symmetry on her face. I'm looking at the skin on her face. Her skin is intact, it is dry, there's no lesions, it's not moist. I'm going to go ahead and look at her hair and scalp. So come around, you can look at their hair, you can comment on the cleanliness of the hair, look at the scalp, noting for any nodules, any abnormal nevus. You would do it, of course, on both sides, and no infestations in her hair. You can go ahead and palpate her scalp. Any tenderness here? Okay. So I'm going to go ahead and test cranial nerve 5, which is a trigeminal nerve. Go ahead and clench your jaw, open and close, side to side. Any tenderness there?
No.
There was no clicking or anything like that. And then go ahead and test your facial nerve. Go ahead and smile for me. Puff out your cheeks. Don't let me push the air out. Don't let me push the air out. Good. And then as I already commented, her face is symmetric. Go ahead and raise your eyebrows for me. Very good. So cranial nerve 7, her facial nerve is intact. Now I'm going to move on to your eyes. I'm going to look at her eyes, inspect her. There's no drainage coming from her eyes. Her eyelashes are curling up on the top, down on the bottom. I'm going to go ahead and touch your lacrimal ducts. Any tenderness here?
No.
No drainage?
No.
And I'm going to look at her conjunctiva is pink and moist. I'm going to go ahead and inspect her pupils. You can stare just kind of right at my nose for me. Right eye constricted, left eye constricted. So her pupils are equal, reactive, responsive to light. I'm going to go ahead and shine this light right at her nose, and I'm looking for the reflection. This is the corneal light reflex, and it is equal and present. I'll go ahead and do the cover on cover test. Go ahead and take your right hand, put it over your eye. All right, and you can go ahead and put it back in your lap. I'm looking to make sure the eye doesn't wander. Go ahead and do it again on the other side. All right, and you can put it down. The cover on cover test is intact. Go ahead and I'm going to test your fields of gaze, which is cranial nerves 3, 4, and 6. So go ahead and look at my finger. I'm gonna use a star pattern. This is what they call this. You could do an H. I'm going to come in for accommodation, and I should cross. So her cardinal fields of gaze or extraocular movements are intact. Okay, now for the fundoscopic exam. Go ahead and get the otoscope. To do a really good fundoscopic exam, the best way to do it would be to turn the lights down in the room. I'm going to have you kind of look over my shoulder, okay? And what I'm going to do is put my hand on her shoulder. Some texts say to go ahead and put your other hand on the forehead. So if you're examining her right eye, you use your right eye, okay? Make sure you read the text on this to perform a good fundoscopic exam. All right, so I'm going to come in here. And right now I see the red reflex. So I'm going to go on in. Now I oftentimes will take my pinky and end up hooking their chins because you have to get close to you have to get almost to their eyelashes to see the vessels in their eye. So I see the retina, I see the vessels of her eye, and I'm coming across. Her vessels are intact, there's no nicking. I am seeing the optic disc. There's no cupping. It is creamy orange. And that's how you do a fundoscopic exam. Moving on to the ears. So you look at her face, observe the position of the ear. that the pin of the ear should be in line with the outer canthus of the eye. Any tenderness?
No.
Any tenderness?
No.
Any tenderness?
No.
Okay, I'm going to go ahead and look at the tympanic membrane. On adults, for the ear, you will pull out and up. And make sure when you go into the ear that you're inspecting the canal. All right. Her tympanic membrane is pearly gray. The cone of light is at 5 o'clock. There's no redness, there's no bulging. Moving on her facial exam, I'm going to go ahead and inspect the nose. Her nose is symmetric on her face. There's no drainage coming from her nose. I'm going to go ahead and palpate the bridge of her nose. Any tenderness here?
No.
Okay. I'm going to palpate her sinuses. Any tenderness here?
No.
Any tenderness here?
No.
Okay. I'm going to use my otoscope again and take a peek at her nose. All right. I'm inspecting her nasal mucosa. It is pink and moist. You can go ahead and look into the nose. You should be able to see the middle turbinates in here. Her nose is, the nasal mucosa can be pink, pinkish red, and it is intact. Any trouble with your sense of smell?
No.
If the patient did have any difficulty with their sense of smell, you would have to verbalize a test to assess for smell. Go ahead and the other. So her nares are painted. So let's move on to the mouth. Looking at her lips are intact. They are symmetric. As we've been talking, she is articulating her words, so her cranial nerve 12, her hypoglossal nerve, is intact. Go ahead and open your mouth. Say ah.
Ah.
Stick out your tongue. Okay, so go ahead and close your mouth. Cranial nerves 9 and 10 are intact. I inspected the tongue. It protruded midline. Open your mouth again. Her hard palate is fused. Her soft palate is moist and intact. Her buccal membranes are moist and intact. There's no lesions. Go ahead and lift your tongue to the roof of your mouth, looking at the floor of her mouth. There's no masses. There's no discolorations. You can rest your tongue normally. And I'm looking at her teeth. All of her teeth are intact. There's no dental work, no caries noted, and there's no unusual breath odor. You can go ahead and close your mouth. Her tonsils, I didn't see any enlargement of her tonsils. If they were enlarged, you would need to grade them. Okay, now onto the neck exam. Of course, first I'm going to inspect the skin on her neck. It is dry and intact. There's no scars, no lacerations, no abnormal nevus. I'm going to look at the trachea. It is midline on her neck. And so now we can do range of motion on her neck. So actually go ahead and put your chin down to your chest and back to midline, and now back if you can. Okay, straight. Now could you put your ear to your shoulder, and then your ear to your shoulder, and then circle around if you could. Any tenderness there?
No.
The range of motion to her neck is intact. Now I'm going to palpate her lymph nodes. I would encourage you, however, you're going to palpate lymph nodes to do it in the same pattern all the time, and it will just become second nature. So I do preauricular, postauricular, posterior cervical, anterior cervical, submandibular, submental, and then I do supraclavicular. After I assess the lymph nodes, I'll go ahead and assess the vessels in the neck. So looking for any pulsations. Actually, it's thin. It wouldn't be an abnormal sign to see the carotid pulsation. I'm going to go ahead and palpate the carotid. Of course, you're going to do this one at a time. Carotid pulse can be a 2 to a 3. Now I'm going to auscultate for carotid bruit. Of course, when you're doing bruits, you're going to be listening with the bell of your stethoscope. And there is no bruit auscultated. Okay, now let's assess your cranial nerve 11, which is spinal accessory muscle. Put my hands on your shoulders, shrug your shoulders for me. I put my hand on your face. Go ahead and push your face against my hand. Push your face against my hand. Her spinal accessory cranial nerve is intact. Lastly, I'm going to go ahead and palpate your thyroid. There's two ways to do a thyroid exam. You can do it anterior or posterior. A better exam is done posterior. So Ashley, I'll have you move your legs over to the side. I'm going to come behind you, and I'm going to put my fingers on either side of your thyroid. The best way to do it is I rest my fingers right on her clavicle. And then you would have them take a drink of water. For right now, I'll have you swallow. Go ahead and swallow. Okay, I don't feel any nodules, any hardness around where the thyroid is. It would be within normal limits not to palpate the thyroid. Now we'll move on to the upper extremities. First, I'm going to inspect her upper extremities. Her clavicles are symmetric, so are her shoulders, and her scapula. And they are symmetric. I'm going to go ahead and palpate her joints. Any tenderness here?
No.
Palpate her chromium process. Any tenderness?
No.
While I'm down here, I can do capillary refill. It is brisk. Okay, let's test range of motion in your shoulders. A couple ways you can do this. One of them is like this. Go ahead and mimic what I'm doing. And then the other way is to go out, up, down, all the way down to your sides. And you go in front and up, and hyperextend if you can, and then down. And there we go. Okay, and that's the shoulders. Elbows are easy. Yeah, and then rotate your wrists for me. And open and close, open and close. Any tenderness there?
No.
Okay, let's move on to deep tendon reflexes. A couple ways you can do the elbow or the triceps. Go ahead and relax your arm for me. Feel like it, just give me all the weight of your arm. You want that arm to be as relaxed as possible. And strike. Or you can relax, tell them to relax their arm down as much as they can. Feel for the tendon and strike. Okay, and then the biceps. I try to isolate the tendon. And then the brachioradialis. She has a watch on under there. Okay, so her deep tendon reflexes are +2. Your hand grasp. Go ahead and squeeze, and her hand grasps are equal bilateral. Now onto the posterior chest. As always, you're going to be looking at the skin in the back of the chest. If this was in a real clinic, you would have your patient in a gown, and you would bare the back of their chest to see the skin on their chest. Looking for abnormal nevus, you're looking for any scars, any lacerations, any discolorations. I'm looking at the symmetry in her chest. I'm looking at the shape of her chest. If the AP diameter is 2 to 1, I'm looking at how she's breathing, if she's having any respiratory distress, if her respirations are symmetric. She doesn't appear to have any difficulty in breathing. Now I will auscultate her lungs. Okay, Ashley, every time I touch the stethoscope to your chest, go ahead and breathe for me in and out your mouth. Okay, now I'll move on to vocal fremitus. Ashley, every time I touch the stethoscope to your back, go ahead and say 99.
99. 99. 99. 99. 99. 99.
And the tones should be muffled. Okay, now I'm going to percuss. And it should sound resonant. I'm going to go ahead and percuss under here too. Okay, now I'm going to go ahead and do tactile fremitus. Every time I move my hands down, say 99. Go ahead.
99. 99. 99. 99.
And the vibrations should lessen as we go down. Lastly, I'm going to do lung expansion. Place my hands on either side of her spine, right below her scapula. Go ahead and take a deep breath, Ashley. And your hands should part equally. Okay, on to anterior chest. Of course, we're going to inspect the skin, looking for any scars, any discolorations on her skin. Then I'll finish auscultating her lungs anteriorly. All right. Ashley. Again. Again. And again. Okay. One more. Last one. While I'm auscultating, I'll go ahead and auscultate the heart sounds with my bell and ape to man. You can just breathe normal. Go ahead and listen with my bell. Okay, now on to palpating the apical pulse. On a woman, if she's particularly large breasted, you could do this when they're supine and have them raise their breast tissue for you. Ashley, would you mind go ahead lifting your breast tissue so I can palpate? Yeah. Now Ashley is thin and I can palpate her apical pulse. Go ahead and relax down. It is not an abnormal finding not to be able to palpate that pulse. Position, I'm going to go ahead and auscultate your cardiac sounds again. In the ape to man pattern. First with the diaphragm, listening, noting for any murmurs, any extra sounds, S1, S2. And while she's in this position, I'll also palpate the PMI. If you're having a hard time palpating the PMI in this position, you could have the patient turn on their left side a little bit. Go ahead and turn your left side, Ashley. And you could palpate it that way. This concludes the anterior chest exam. Now for the abdominal exam, of course, you're going to put them in a supine position. While they're supine, I'm going to note for any jugular vein distension. I do not see any. Of course, on a patient, you would expose the skin on the abdomen. So you would inspect the skin on the abdomen. You'll notice, you will look for any pulsations in her abdomen, any peristaltic waves. You're looking for the skin on her abdomen, make sure it's symmetric. You're looking for any cyanosis signs on her abdomen, any abnormal nevus. Her skin is intact. Okay, now with the abdomen, of course, it's a different order. In the abdomen, then you auscultate next. So auscultate all 4 quadrants with the diaphragm. Her bowel sounds are intact. Now with the bell, I'm going to go ahead and auscultate for bruit on the aorta, renal, iliac, and femoral. There were no bruits auscultated. Next, on to percussion. In the abdomen, you should percuss tympani. I would encourage you, however you're going to do your percussion and palpation, that you just do it in a pattern. Okay, now I'm going to percuss the spleen. Percussion of the spleen can be done 2 different ways. Explanation of these is in your text. I'm going to go anterior axillary line percussing starting at the 6th rib on down. and it should be tympany. If you heard dullness, that could be a sign of an enlarged spleen. The other way to percuss a spleen is to come to the lowest intercostal space. And Ashley, go and take a deep breath for me. And had she had an enlarged spleen, you would have heard some dullness as she took a deep breath in. Okay, now on to percussing the liver. So to percuss the liver, you're going to do top down, bottom up. That was a little duller. Okay, so right there. In a patient, you would put a mark, and then you go to the area of the umbilicus, percuss up. Starts to get more resonant there. So you would measure here and here, and on in this particular area, 4 to 6 centimeters. Okay, now onto palpation. So I palpate in a circular pattern. So you're going to go light to dull. Of course, watching your patient for any signs of distress. You're palpating, of course, for any masses. I don't palpate any masses. I'm going to go ahead and palpate McBurney's point, which is 2/3 way from the umbilicus to the anterior superior iliac crest, right here. And I'm going to do repound tenderness right here. Any tenderness right there?
No.
No. Palpating the spleen. It's an AP palpation. Any tenderness here?
No.
Okay, and the liver, 2 ways you can palpate the liver. You can take a deep breath and feel for the liver. There's another way to do the liver. It's called the hooking procedure. So you kind of hook your fingers around their rib cage. Deep breath in and out. As they exhale, you hook underneath their ribs one more time. Okay, and had they had a cirrhosed liver, after you hooked in there, it would have bumped up against your fingers and it would have felt firm. That would be a sign of a cirrhosed liver. Of course, if you're feeling the liver down here, not underneath the ribs, this is a sign of an enlarged liver. Now into palpating the kidneys. This is also an A to P. This is a deeper palpation. Any tenderness here?
No.
Any tenderness here?
No.
Okay. On some particularly thin patients, you may be able to palpate kidneys, but it is not an abnormal sign not to be able to isolate those kidneys between your fingers. And now onto the hip. First you palpate. Any tenderness here?
No.
And I'm going to push together. Any tenderness here?
No.
Okay, in this position it's easier to do a passive range of motion. So I'm going to pick up her leg. Any tenderness there?
No.
And down, and then I'm going to rotate it out and up. Any tenderness there?
No.
Okay, so the passive range of motion in the hip is intact. And you would do that on both sides. Okay, now onto the lower extremities. I did have Ashley remove her shoes. So first you would just inspect the lower leg, inspecting the skin on the knee, of course looking for any scars, lacerations, any swelling of her knee. Her knee is intact, of course. On a patient, again, you would want to expose the skin on their leg and look at the joint better. And then looking at her ankles and feet, of course, you would note any the hygiene of the feet and the nails. You would note any swelling of the ankles, any disformities of the feet. Then you're going to go ahead and palpate the knee. Any tenderness here?
No.
No? So while I'm palpating, come down. Any tenderness here?
No.
And you would palpate down, of course, noting for any lack of sensation. If the patient comments that they don't feel you touching them and their toes, of course, that's a sign of neuropathy. All right, and Ashley, could you extend your leg out for me at the knee and back down? And if she was standing, she could hyper-extend as well. And go ahead and flex your foot up and down. Can you rotate your ankle for me? And what about your toes? Can you push them down and up? Any tenderness there?
No.
Okay, the range of motion in her knees, ankles, and feet and toes are intact. Now to check deep tendon reflexes. Ashley, could you scoot forward for me a little bit and try to get this leg to dangle as much as you can? There you go. Actually, back a little bit for me. There we go. All right, you're gonna palpate the patellar tendon. it is. And for the Achilles reflex, it's easier to put their foot in your hand and kind of extend their foot up a little bit. Relax your leg if you could for me. And see how it flexes down. And then for the plantar reflex, some people call this the Babinski reflex. Okay, now on to the neurologic exam. I'm going to observe for dystaxia. Ashley, could you run your heel down one shin and then down the other? And that is intact. Next, for the neuro exam for your test, you will have to discuss some of these tests, or you could perform them. A lot of students find it's just as easy to perform them as to explain them. But you would discuss exteroceptive sensation, which would be testing for superficial pain and temperature, and you would have to discuss tests that you would perform on a patient or demonstrate. Proprioceptive sensation, you would discuss tests for motion and position and vibratory sensation. Cortical sensation, discuss sterognosis, graphesthesia, 2-point discrimination. We already did the plantar reflexes, that of course is neural. And then next you would observe them walking. Okay, now Ashley, I'm going to have you go for a walk. So if you could stand for me, I'm going to have you walk normal to that blue line, and then you could turn around.
Okay.
Okay, now if you could turn around and walk back to me on your toes. Okay, and turn around and walk back to that blue line on your heels. Very good. And come on back to me walking, putting your toe to your heel. Come on back that way. All right, very good. Now, if you could stand looking right here, I'm going to do the Romberg test on you.
Okay.
Go ahead and look straight. Now, on the Romberg test, of course, I'm testing balance. Put your hands out and close your eyes. Now, you're here to steady them, because if they have a lack of balance, they could start to sway or stumble. Okay? The Romberg is intact. You can go ahead and open your eyes. As she was walking, I was observing her legs and feet for pronation, and of course, any uncoordination, any dystaxia, anything like that. Okay, now on to assess her spine. I'm going to come around back. Ashley, if you could turn this way for me and take one step forward. Okay, I'm going to observe her spine. It is symmetric down her back. There's no swing. Ashley, could you take your hands and put them forward like you're diving for me? Go ahead and dive down. And touch your toes if you can. So I'm running my fingers down her spine, looking at the curvature of her spine. It is straight. Come on, go ahead and come back up. Any tenderness as I palpate your spine?
No.
Okay, now could you use just turning your spine, keep your hips straight, turn toward that way, yep, and this way. Very good. And straight. And then could you kind of curve your back, there we go, for me, and stand straight. Any tenderness there?
No.
The range of motion in her spine is intact. All right, that concludes the spinal exam. Ashley, you can go ahead and come back here and have a seat. And that concludes the head to toe exam. Thank you very much, Ashley, for your help.